I'd like to introduce special guests today. Our Dr. Cal Kiram and his family are hosting Dr. Mifila this weekend, and they've come and are giving him transportation. Dr. Mifila is going to be talking to us, and he speaks very good English. However, he's going to say a word called secu, or secu. Secu. And what secu means is, it's a French term, which I will not try to pronounce for you, but what it means is, basically it's talking about the Christian church in Ubangi.
It's the same as the EFCA.
It's the same as EFCA for the United States as it is for the Congo. So when you hear the word secu, it's talking about the church organization in Ubangi. So anyway, at this time, Dr. Mifila, it's just such a pleasure to have you come. Come and share your heart and tell us about how you love Jesus and what took you to Tandala.
Good morning, everybody, and the Lord is good. I'm very, very happy and very, very thankful for being here, for having this opportunity of trying to share what I can have about what the Lord is doing in Africa, especially in Congo, and more especially in Tandala Hospital, through the church there, through the Secu, like she said, which is the community of the Church of the Christ in Ubangi. That's the way we translate it in French. So it's still like the IFRI here in America. I'm very, very thankful for you. Oh, okay. Cloud?
Just talk loud.
Yeah. I'm very, very thankful for the church here to accept to have some time for me to try to share with you. And I say thank you for that, and may God bless you really for that. And I'm also want to say thank you for all, I don't know, I will need to shift? I don't know, because this is disturbing me a little bit. Okay. I would like to say thank you, because with the Tandala Hospital is in the north of our country. I will show you the picture maybe for the map so that you can have an idea. And the hospital has been since like 55 years, since it was built by the Evangelical Free Church of America in partnership with the Secu, which is the church, the local church there in Congo. And then it was because of some of the missionaries who went there for sharing the gospel. They felt that there was really a need of having a facility where they can provide medical care for people who live there. And that was a very, very good investment for all the people in the Ubangi, because they really needed something like that. And it was a structure where people can come to get medical care, but also to hear about the gospel. And many, many people has become Christian there in the Ubangi just through the ministry of compassion, through the work the hospital is doing. And that is something very amazing, and we say thank you for God for that one. And thank you for you here for the work and for implanting the hospital there. This is a picture of what we received from the White Cross. I think I've heard about the White Cross and for the compassion and for all the supply they send since I was there in Tandala, and even if when I'm still in Cameroon doing my residency, I'm hearing about that, and it's something which is really touching my head. And I wanted to say a particular thank you for you, for your prayers, and for sending us supply all the time since we need it. So I will try to present myself, and I'm a general physician. For now, I'm a general surgery resident in a training program in Cameroon. The training program is what they call PACS. PACS means Pan-African Academy of Christian Surgeons. So it's an organization that was founded by the Christian and Medical Dental Association of the United States, and was mainly by the missionaries who were working there in Africa, who felt that there was a need of training surgeons to work in Africa and train them in Africa. So they found that organization, which is in many, many countries there, like in Cameroon, where I'm having my residency, in a Christian hospital, which is Mbingo Baptist Hospital. But there's another one in Ethiopia, in Sodo Christian Hospital. There's another one in Kenya, in Tenwek and Kijabe, and another one in Gabon. And now they are going to Niger, to Galmi, which is also a Christian hospital. So it was a very big opportunity for me, because I'm married. I have 2 kids, as you can see. There's Glody, which is who is 4 years, and then Dan, the second one, who is now 2 years, and my wife is expecting another third. My wife and I, we are expecting another third son, by the end of October. So I really pray that I should be there before she delivers. Then I went to medical school. I went to medical school in Kinshasa. First, I will tell you about my testimony, maybe. And I grew up in Bandundu. Bandundu this is the Democratic Republic of Congo. And Kinshasa is somewhere here, which is the capital where I did my medical school. And here is Bandundu, is where I grew up. My father is actually a nurse, is still alive, and my mother was just a housekeeper taking care of the children. My father was a nurse, and then when I came up, my small brother came up also. My brother was about 3 years, and I was about 6 years. My father divorced with my mother. And then my mother went somewhere else, and we stayed with our father, who got married to another wife. And that wife was the reason why my father divorced. So my mother didn't want to stay with another wife, and she went, and then my father took that lady, and she was our stepmother, and we spent all our infancy with her. And then we had a very, very, very hard time to live with her. We were children, but she was trying to do everything just to make us being unhappy. We were working very hard in the house and going to look for cassava or to look for vegetable in the bush, even when it's raining, and it was very hard. And looking for firewood to come with it so that she can cook. We worked very hard, and she was sometimes beating us and saying things that were not correct. But at that time, I didn't really know Christ, right, because I was still small. And I started going to one of the Catholic church which was closed, because I liked music. I like singing, and I like listening to the music, like it was this morning here. And while going there, I started learning about Christ. And then it was time to try to get into a program that was to learn more about Jesus in that church, so that you can get baptized. And it's from there that I knew that Jesus is the Lord. And Jesus is love for us. He has much love for us, and he has a great plan for our life. And we can be able to forgive what our mother was doing, and consider it like good thing, because we are learning from what we are doing. What she was like thinking that she's making us to suffer may be something good in our life. So from there, I started being able to forgive her and consider everything that she was doing. She will send me. I will just go with joy, because I started understanding that was a learning process for the future of my life. And today, I was just telling Carl that I'm sure that if I've gone to medical school, working hard was more because I had that opportunity during my infancy. And it was very, very good thing for me to go through all that experience, even though it was hard. But today I thank God, because he made me passing through that narrow and very difficult way. And then I came in Kinshasa to do my medical school. And then it was a bit hard, because in Kinshasa that was a government school, and we were not able to go to worship and to continue to glorify God and to continue to pray and stay with a good environment. Before coming, I went to a seminary to become a priest. I wanted to become a priest to come and share the gospel, but I didn't get that done. And my father wanted me to become a doctor, since he was a nurse. And he said, okay, it's good for you to go to medical school, and it will be good to get trained like a doctor and then come to help. And I accepted that. When I was coming from Bandundu, which is a bit in the west, and then coming to Kinshasa to do from Bandundu there and to come to Kinshasa to do my medical school, we came through a boat. We didn't have money to go through a car. And then I was coming through a boat, sharing places with the goats, with chickens, with everything like that. And it was hard because I fall in the water, in the ocean. In the huge river that bring water to the ocean, the Fleuve Congo. I think people know that. Those who come there. And I was almost died because it was a very big river and the boat was still moving. But I was bringing somebody who was coming to Kinshasa for the first time. I was the only one who knew where to bring that guy. He didn't have any information about Kinshasa. So when I was going, I knew that I'm dying. I started thinking about that guy. I said, what is he going to be? How is he going to reach the house of his sister so he can stay there? It made me feeling unhappy. I knew that I'm dying, but my concern was more about that guy. But suddenly, like, something pushed me to come up. And when I came up, where they tied the barge of the boat with the motor of the boat, there was a big cable that was still pending on the water. The distance was about maybe 1.5 meters or 2 meters. So I touched that cable, and that is what saved me. And for me, it was a very big tournament of my life, even if I already knew about Jesus, but that was something that completely changed my life and made me to understand that maybe God has a plan for me. Until today, I continue to look what God wants me really to do. Have I already done it? Is it still to come? I used to pray, I continue to pray, and I don't know what God wanted me to do. Why did he save me that day? And to continue to stay alive. So I hope, maybe I've already done it, maybe I've not yet done it, and I continue to consider each minute of my life, each thing I have to do in my life, I used to consider it like is what God saved me that day so that I can do for his glory. So very thankful for that, yeah. And then when I went to medical school in Kinshasa, I met one of my friends was there, Narcisse. He was coming from Ubangi. I didn't know about the Equateur. I was never been there. And then when we graduate from medical school, since there's a problem in Congo there, when you finish your medical school, you go directly to work. There's no doctor or working in many of those hospitals. There are still nurses holding the hospital. So you graduate, you go directly. You don't go through a residency program. So when we finished the medical school, Narcisse went there to Ubangi to work, and he was having too much responsibility. There was Dr. Sana, who was still there, but he was almost alone at that time. And they needed somebody because that was after the war. Most of the missionaries, like Dr. Tim, like Tom, who were there, they left this place, and Sana was working alone. So Narcisse went there, and there was a need that was about for taking care of about 250,000 people. So he decided to call me if I can come and help to work with him. And I say, yes, I will come. He told me the salary is not going to be very much. I said, no, don't worry about that. I will just come. And I take my luggage and take the fly and went there to work with the church. That's why from being there, and then I knew about the CQ. I went to the church, and I felt that that was the best place for me to be, because it was a Christian environment where people can share the gospel, where people can consider each other as friend, as brother, and it was a very, very good environment. And since I grew up in a village also, which was not a big city like it is here, so I felt myself like at home. And then I started having the responsibility of being the medical director of the hospital for 3 years. And we felt that there was a need to get somebody to get trained to come and do some surgery so that he can go back to help Papa Bama, who has been there for more than 30 years. He's a nurse who does all the operation, C-section, hernia, appendectomy, and all kind of operation by himself, because there's no surgeon there. So then the CQ with the EFCA accepted to send me to come to get the residency in this Pan-African Academy of Christian Surgery program. So it was really a blessing for me to come and get this training, which really going to help me to go back and continue to serve in Tandala, because I know people really need somebody who is trained, who can provide them good standard care, and the way it is maybe here, or maybe not exactly like this, but continue to improve progressively until we can reach this level, or maybe go more than this level. Continue to trust that. Yeah. So this is Tandala Hospital. Tandala Hospital is was created, like I said, is 55 years ago by the EFCA with the SECI and with some help of the government there. This hospital is 185 beds, but it's different than here, because here you have one bed for one patient in one room. But in Tandala, you will, for those who have gone there, they will see that we have sometimes 30 beds or 40 beds in one ward, like it is like this. And then you have the nursing table. They come and then they can continue to see patients. So it's completely different. And we have a problem there. There's no running water. There's no electricity. Like it is here. We have a generator that we can turn on maybe for 2 days a week or 3 days a week from 7 a.m. to maybe 2 or 3 p.m. And then we can do some of the things that need to be done with electricity. We don't have anesthesiologist. We don't have nurse anesthetist in the hospital. And there's no running water. So we really have some trouble there. You can see the mattress. It's really difficult sometimes to have a mattress, and then some of the patient will be lucky. They can have it if they just come when we discharge a patient who was on a bed with a mattress. But those who comes after, they will get a bed. You can see this one is actually on a bed without a mattress. So it's very, very hard for people to be admitted there. And then we have many challenges there. The other problem is like the roads. To reach Tandala, normally you will fly from Kinshasa to Gemena. Kinshasa is somewhere here. You will fly from Kinshasa to Gemena and then take a car for about 70 kilometers to reach Tandala. 70 kilometers? About 45 miles. Yeah. Then the road is the one you've seen there. It's terrible, especially during the raining season. And sometimes it will not be possible to go that way. They will advise some of the missionaries who come to go through the Central African Republic, which is Bangui here in the north, and then you can cross the river and then take a car to come to Tandala, which is about here, and that will be about how much? Many kilometers?
8 to 12 hours of driving.
8 to 12 hours of driving in a terrible road with terrible bridge. But we say thank you to God, because for all of our missionaries who have been coming there, even though the roads are bad, even though the system is not very good, almost all of them still come back here.
Almost
everyone comes back. We've not lost any missionary because of the road, because of the plane. So we say thank you to God for that one. So God is amazing. And then, this is a city train in Kinshasa, which transport people like from one place to another place. You can see how people are trying to get place. Kinshasa is a big city of about 11 million people living there in very compressed and very, very dirty. I don't know what.
Ruined is a good word.
Yes,
ruined.
Very ruined area. So, and this picture for me used to give me about some idea about how the political condition of the country has been for the past year, and how the economical situation of the country, and how the administration system of the country has been. I used to see that in this picture. But for now, I can say that there is much hope, because of we've been having some peace for like maybe these 5 years, and then we still hope to have peace for the rest of the time. And there's kind of a new generation of people, of Congolese who are coming, who knows God and who try to make things on the right way. And that is something very, very positive for the country there. And in Tandala, Tandala is covering a population of about 250,000 people. There's no surgeon there. For now, there's only that nurse who try to walk, and there are some of the general practitioners. They have 4 doctors now there who help also. They will go there, they learn how to do C-section, how to do hernia. They can help for those operations. But there's no surgeon for all the 250,000 people. But I think it should be more, because the church, the Seki, has other health centers, about 45, that will give a population of about 200,000 again.
Yeah, the word there was health centers. They're like small clinics scattered around the country that are run by nurses. We would call it maybe an infirmary here instead of a health center.
Yeah, and then people, most of the people there live with farm. They do farm. They will get corn or they will get peanuts. Then they can sell it and get some money to come to the hospital. But you will see there's no road. There's no road from Kinshasa to Gemena or to Tandala. There is a river, but there's no good boat that can help with transaction to help people to sell what they are producing. So people are really poor there. And they don't know about how the world is like here. If I tell them that the world here, the roads are the way it is, nobody will think, nobody will understand that. They don't think that there are roads, there are bridges like I've seen here, or there are cars like I've seen. They don't think, or there are clean hospital like I've seen here. Nobody think that is possible there, because they are not open to the rest of the world. And this is a family, a house of one of the family we went to visit when we were giving vaccination when I was still working there. And you can see they live in this kind of house. There's no room that, okay, this is for the parents. There's no toilet inside, and they cook inside. The father sleep somewhere, and then the kids somewhere there, and they have some space to cook. They have some space to keep their clothes, and it's hard. Even to get soap sometimes is difficult for some of the area where you cannot reach them. So people are still really, really in very difficult situation. And then poor, they cannot afford the price that we give to pay for the operation we do in the hospital. So it makes the hospital to continue to run like in deficit, because people doesn't have enough to pay for what we do. And they will go for traditional treatment before coming to the hospital when it's complicated case. And then if they go...
Cal, I don't understand what he's talking about. Can you back up?
Yeah.
Traditional.
Our word in English would probably be witch doctors.
Okay.
Witch doctor.
Witch doctor?
Yeah, witch doctors.
Wishy?
Wish.
Wishy, yeah. They don't use that term as much in the church, but that's what we would call them. Traditional
So the
healing.
people will go to witch doctors first before they'll go...
And then by the time they come to the hospital, their case is very severe.
Very severe.
He could show pictures, but I asked him not to this morning.
Yeah,
But they get the worst of the worst of the hardest cases at their hospital.
Yeah.
And so the people don't go to the hospital first. Why do they choose a witch doctor?
Because they don't have money.
Okay, so they think it's just...
For example, a cesarean section, $40.
$40. This is actually.
That's what the cost for a cesarean section.
And they will not be able to
But
pay.
they don't have that money because they don't make any money. They live off the land, I think is how we would say.
So a witch doctor is affordable.
Because they can pay with a goat.
Okay.
They can give a chicken or fish. Yeah, a fish, and then they can, yeah.
Okay, thank you.
And it's also, some of it is all spiritual, like Stacy was pointing out. Some of it is a spiritual mindset.
Yeah.
That's the way it's always, it's tradition. One thing that we talked about is that in America, it's always bigger, better, faster. In the Congo, do it the way always has
they
been
do
done.
that. Doesn't change.
Does that make sense? Yes, am I right?
You're right, yeah.
Okay.
That is it,
Anyway,
yeah.
I'm sorry.
Thank you. That's okay. Good.
Does that
Thank
help?
you, yeah.
I think we'll understand now.
Yeah. So it's like he said, we have the worst of the cases that comes there. When you have a hernia, you don't need any examination to say that this is hernia, because you can see it maybe before when the patient is just coming at the door. You see, oh, he has hernia, so it's big. And I've tried to remove those pictures, but when you don't have time to, because you will see the patient coming with a hernia. You will see the patient coming with a breast cancer. Just when he's coming in, you can say, oh, that is a breast cancer. You don't want to palpate, to feel the node, to feel the lump, because it's visible from far. So we get the worst of the case because they go somewhere else before coming to you, and you get them at the very advanced stage. There are some of those who can come earlier, those who go to school, they can understand, or those who stay very close to hospital who has some money, they can come early, but most of the patient will come very late in a very advanced condition. And then this is one of the operations we're doing there. You will see we have light in there is what they call cyanolytic, but there's no light to use most of the time. You will do the operation during the day, and you just use the windows and the sunlight so that you can see inside the operation. So we don't rely on the light like this to do our operation. Sometimes we'll turn on the operation during the night to do like a C-section, and some of the time the light goes off in the middle of the operation because the fuel got finished. We have one generator that we used to run, but sometimes the fuel got finished exactly when you were starting, and the administration didn't plan to buy it that week, and you have an emergency. You have to do everything you can do just to save the wife. I think Dr. Carl, when he was there, some of the operation was done in the night with a torch light. Flashlight, just to see and finish the operation. But we have to do that to save the patient, to save the mother, or to save the child's life. And then this is Bama. He's one of those who has really helped us for many, many years. This in the middle here, he has been working there for about more than 35 years. And he worked with some of the missionaries who worked there, like Tom Kynes, like Colby, and people like that. And he learned how to do those operations, like hernia and appendicitis. And he does almost all those things the way he saw people doing it. He didn't go for training for that, but he saw people doing that, and he's just a blessing from God that this guy is there. It's just God's gift for the Ubangi there, because if he was not there, I don't know how things could have been done. And we graduate from medical school without any surgical experience. When we go there, he's the one who teach, even me, when I was coming, he's the one who teach me how to handle the scalpel, how to do the exploration, to open the abdomen, how to do a hernia, until I was able to do that so that he can get some rest. That's what he was doing. And then now I've come to the training, he's still there helping other general practitioners to at least do that so that he doesn't work without non-stop. And he's getting old, he's more than 70 now. He should go to retirement. And we praise God that I got the opportunity of coming to learn and maybe go back. Not maybe, and go back. I have to go back there to try to help with all that work that is waiting for us. And so I have much respect for him because he's doing a good job, and he has put us on the way of being able to do some of those operations that he does. So we have some challenge. Since there's no electricity there, we use pressure cooker to sterilize our material. This is what we use. And you see there is those black charcoal. Charcoal? I don't know how to... Charcoal. To use that to put fire and then sterilize the material. You can see the environment. With charcoal, it's difficult to keep the cleanliness like it is here. It's very difficult because charcoal itself makes the things to be dirty. So, and we pack our instrument in that room and we go do operation with it. So it's very, very difficult. But people don't know that this is not the ideal environment to do this kind of work. They don't know because they've not seen how it is in the other world. So for them, and Tandala is actually the best hospital there. People come from Central Africa, those who are close to us. People come from Congo, Brazzaville, those who are close to us. They come to Tandala because it's still the best hospital there. It's like the Mayo Clinic in the area there. So God is good, and He's really helping people to at least have that structure who can give them some good care. And then water, we use to collect water from the rain, to put in the well, and then take it to come and use to scrub or to wash the instrument or to clean all the scrub. We don't have a laundry service there. We used to do that with our hands and dry them before using them. And sometimes we will use them the next day because you don't have them enough. You will use them the next day because there is surgery to be done and they are still wet, especially when it rained very much. You couldn't get them dry, but you have to do an operation. We take the risk sometimes of wearing them like that, and we take the risk sometimes of exposing the patient to infection, post-op infections, just because we don't have much choice. But God is good. Sometimes there are even flies come in the OR, and you will see it come onto the patient's wound. You just put it away, and next day the patient is good, is doing fine. There's no infection sometimes. And we just say it's God's grace. Because we treat, but God is the one who heals those patients. Amen. And it's very, very good for us. But we like to improve and to go to a standard and a better environment to provide care for those patients. And this sometimes during the dry season, there's no water there even indoors because it doesn't rain, and you have to go take the water from a small, I don't know how you call it, womp?
Well, it's a spring.
A spring.
It comes out of the side of the...
So you have to go to take water and bring it there in the hospital to work. And they cannot carry a very big tank. They will carry the smaller size they can. And then they bring it, and you have to have many people to do that so that you can get water and then use it for... So it's very hard some of the time.
So the cisterns are for the rainwater?
For the rain.
And then the rest of the water you get from the spring?
The spring.
The spring, yeah. So this, sometimes we've been sterilizing gloves. Not washing the glove, reuse the glove. Wash them, dry them, and then put some talc just to reuse them, because you don't want to expose yourself, and you have to try to have that to do an operation. But we tried to fight against this one when I was still there. Before I left the hospital, we were not using it again. We were doing the operation with the hospital. We were a bit able to get the sterile single-use glove. So we were using that, and I think it's still working like that for now.
Excuse me, sir.
Yeah.
How prevalent is the HIV there where you're at? I know it's a big thing in Africa.
Yeah, HIV is one of the biggest problems there. And there is always a political... the politics plays with the rate of, the real rate of HIV. And they will not allow the doctor to give the right rate you've got, because they don't want to give bad impression maybe from outside. So the rate when I was there was 4.6%. That's what they say.
Official.
But, yeah, official number. But from my experience, because when we do transfusion sometimes, we'll collect the blood, but before collecting the blood, we do the HIV test, and the number was looking more than that. Was actually more than that. So we sometimes don't understand where the number that the government is giving back to us comes from, but we accept it. So, but I think it should be more, far more than 4.6%. But it's true that now there's much people, much NGO that help with HIV, giving maybe people to know how the HIV can spread. And in the church there is a program what we call PACIT. We have pastors and other young people who goes to the church to teach about HIV and ask people for abstinence, and continue to encourage young to stay until they get married before having relations like that. So he's trying to work. I think he's working. So the number can actually be going down small. And the church, the secu is very, very organized for HIV campaign to prevent people not, compassion to get that. Yeah. And then this is the OR, we've said it, and then these are the wards. So we don't have an anesthetist. There's no nurse anesthetist. There's no anesthesiologist. And I'm going to go back there in 2 years. I'm scared of being there, not being able to do the surgery that I've been learning, because there's not going to be somebody who can give general anesthesia or giving good spinal or doing a good pre-anesthetic review of patient and doing a good monitoring of the patient during the operation or doing a good post-op, post-anesthetic care. So I would pray that we need to have somebody who can come and help us to be doing. In Kinshasa, we can find those who graduate from some of the school for the nurse anesthetist, and then he may need some more training from or changing experience with those from here who can come and teach him more how to use the instrument, the new material that we can have to work there. So this is one of the priority really for me to go back there. I would like to have somebody who can help with anesthesia. When I went in September, I actually did it. Somebody who was coming from Congo Brazzaville with a tumor in the mouth. I had many operations done, but one of those came with a tumor in the mouth, and that was on the heart palate. I'm not an ENT doctor. I'm not a maxillofacial surgeon, but in that setting, when you go as a surgeon, you are surgeon. And all surgeon, you do everything. You do ENT surgery, you do maxillofacial surgery, you do head and neck, you do chest, you do general surgery, you do ortho, through everything, neurosurgery. So it was hard for me because we get some knowledge about that, but we don't do that often. So, but in that setting, I had to do that. And I did that operation with local anesthesia. Since I didn't have enough about how to have an IV line so that the patient can be monitored during the operation, I didn't think about that. I just started doing the operation, and the patient was collapsing during the operation. When I asked, what is the blood pressure? Nobody was taking the blood pressure. What is the pulse? Nobody was doing that.
Let me explain a little better what he's saying.
Yeah.
He is training in Cameroon. All those things are taken care of. All of those things are taken care of. All he has to think about is the operation. But when he goes back to Tandala, if he doesn't think of doing it, it doesn't happen. And so that's why he needs a nurse anesthetist there. For him to do the more complicated operations, he needs to think about the operation, not about getting the patient ready for the operation, caring for them during the operation, and caring for them after the operation. So that's why he's coming to this point about needing a nurse anesthetist. I can't say that word.
Yeah, nurse anesthetist,
Yeah. Okay.
Okay, yeah. So I think, and then these are the needs. I think for now, what I really think is important is to get electricity there in Tandala, to get running water in the hospital, to get a new surgical wing, because the one that is there has been for 55 years and is really old. And you can see where we sterilize, the material is not adequate. And we don't have toilet adjacent to that. We don't have a changing room. We don't have a small store where to keep the material. There's no library for you to review some of the operation before doing the operation. So I think, and there's no post-anesthetic in it. So I'm thinking that if they can get that done before I graduate, if possible, by God's grace, it's going to be very, very helpful for me to work. And I will probably be having some of the people coming here to come and help maybe for a short while. They will like to work in a good environment, and then it will give them more possibility of come and help most of the time.
So if you bring a surgeon from the United States to train you, you want the conditions to be better, that they're more used to working.
Oh, yeah.
Because I'm sure that our surgical friends here would not like
will not
when the flies are coming
with the flies coming in, and so that is that is my prayer too. And then the other thing is that we need to equip that OR. It's not just building the OR, but it's also to provide the material that we need to have a surgical, like hernia set, like general surgery set, or orthopedic set, or some of the OBGYN. We do C-section, we do hysterectomy, so we need those materials. 2 days ago, Papa Bama sent a message to us here that is even not having scissors. The medicine bomb that we use to dissect the tissue is not having that. So he was asking if we can send it urgently. There was Thelma Landry almost close to go, and I tried to get the thing. I couldn't get it. So I've asked Thelma to go, and maybe by God's grace, before I leave, I can get some of those scissors and maybe pack it in a very small way and then see how we can send it so that they can use it to try to help people there. And that is something really urgent for now. And then I think it will be also good to plan to reinforce the administration of the hospital. I've tried to mention that with the SECU leaders and also with the EFCA here leaders to try to help us to reinforce the administration so that we can be able to work in with a good administrative system and be able to maximize our income and to continue to be able to be self-sufficient, I think, self-sufficient, yeah. And also to be thinking about training another colleague. I will not be the only one to work there for, say, okay, we've trained one surgeon and it's finished. But what about the future? We need somebody else. I will not be able to be doing everything every time. So we need somebody else to get trained. Locally, I can train some people when I go back who can help me so that at night they don't call me all the time when there is even a small laceration. Some people can do that so that I come during the day and do the best I can. And then go to the night if it's really something I'm sure that patient's life will be in danger if I'm not going there, so I can be selecting cases to go. But we need somebody to get a training like in OBGYN, like in maybe pediatric, like maybe in internal medicine, or in other discipline like physiotherapy, or like ortho, trauma, thoracic surgery, and neurosurgery, and other possibilities. So that is my prayer too. And my far vision for Tandala is that I will really like Tandala to become a training program hospital too. And maybe the CMD, the Christian and Medical Dental Association, will accept to come there to work in Congo and to implement a training program in Tandala. But it's a long way to reach there. We have to reach the standard of a training hospital, and that means having water, having electricity, having the material, having a good OR, having other attending like in ortho, ENT, chest, and other things like that. But I think it's not impossible with God, because nothing is impossible with God. Yeah. And then we also have some good things. Tandala is not just, oh, everything is negative. I don't think so. We also have, God has been doing and working very much since throughout all these years. And we've got opportunity of having other potentiality, like we have internet there. So when you are in Tandala, you can still get into contact with people in the other world. But it's not everybody who use it there, because to use the internet, you will need a laptop. Most of the doctors are having laptops so they can get into contact with other people, and it really helped them to be able to do some research or to communicate like with Dr. Carl or other doctors here to have some exchange, and it's really consultations and things like that. And we also have an ultrasound machine that helps us a lot with the diagnosis, but there's nobody who is trained to use it there. So there's one doctor who just tried to do whatever he can. I don't know if somebody went there, tried to teach him or not. Dr. Bienvenu? Yeah, he's using that, but he has not been trained to do that. So he's
the
just...
machine is there, but
no one knows how to use it.
How do you use it without electricity?
with the generator.
With the generator. We turn on the generator maybe 2 or 3 times per week. So the patient, sometimes they come, we'll ask them to wait the day we turn on the electricity, then we can do the ultrasound on that time too. Yeah. So we have a lab also which has been renewed with help of people here, with churches. They've sent us some of the microscope and some of the instrument and all other tool that we use for the lab. And our lab actually there is one of the best in the whole province of the Ubangi. Sorry, the whole province of the Equateur. Province of Equateur is, you say, is the size of
was like
Washington State. And then Ubangi is the size of almost the East Washington. And the Democratic Republic of Congo in general is the size of the whole United States at the east of the Mississippi River. So it's a big country with about 70 million people living there. But the country is still not very stable economically. We have, that is another good thing. We have radiographic equipment there. You can see that one is an old army machine, but it's really strong and really helping us. And that guy has never been trained as a radiologist, but he helps us. He's a nurse. They show him how to use it and how to do that, and he's the one helping us very much. He was a lab technician, actually, but now he's doing this just to help us. And then we also have phone there. Cell phone, you can call from there. It used to be under a tree, I think those who went there sometime, we was having I don't know how can you call it? A signal from far, and you have to go stand under one tree to get it and then communicate with people. And you don't move, because if you move, you lose it. So now we have an opportunity. Somebody built, I think the government built an antenna there, so we can communicate with everywhere without problem. So that's another thing that is very good for us. So, and that's why I'm really thinking about the future of all these kids who can do a lot, but most of them are not healthy because there's no a good structure to take care of them. And I think if we can put the hand together and work, and with God's help, we can be able to improve the hospital and provide good health care for them in the setting there. Yeah. And then this is, I could have loved to talk about PACS, where I'm getting my training. The training is in that Pan-African Academy of Christian Surgeon. And then this guy is the program director. He's a Christian. He was trained here as a vascular surgeon. Once, when he finished his training, he felt like he was called to a mission, to help. And then he decided to come to Africa, and they gave him the responsibility of being the program director of where I'm getting my training. He's a good Christian. In the program, that's the advantage. We have both. We do work as surgeon, but the trend has more for compassion and for working as a Christian. And then we have Bible study every Thursday, and we have conferences every Thursday morning to discuss our chapter. We use the books that are used here, Sabiston for surgery, and we use Short Principle of Surgery, which are good books. And then we have books also we use for our Bible study, and very, very good books that help us to learn more about God, more about the gospel, and how we can be able to share that with our patient during the round, or after the round, or during the operation, before doing the operation. And that is something that when I was coming, I saw one of the residents came from Mayo Clinic, was there where I'm doing my residency. And he was like, wow, you pray with the patient before doing the operation? I say, yes, we do that because patients need God's protection during the operation, and we also need God to lead us throughout the operation. We don't do operation by ourselves if God cannot help us. He said, don't do that when you go to Mayo Clinic. I said, why? He said, no, in the United States, don't assume that everybody is a Christian. And don't go to Mayo Clinic thinking that everybody is a Christian. I said, oh, it's good that you've told me that. Because for me, it was like, coming to the United States, they also do that in all hospitals. They pray, but I've realized that it's different there. They are Christian, but they don't assume that everybody is a Christian. So you can pray with somebody if you know he is a Christian, and if he needs some help, you can pray with him. So, and I had an opportunity of one of our attending who came from the Mayo Clinic. He came there. He's a neurosurgeon working at Mayo, and then God helped me, gave me the opportunity of doing surgery with him while he was there. We did craniotomy for intracranial hematoma, and we did craniotomy for excision of a huge meningioma. And then he felt that I was good, what he said, I don't know. And then he told me that one of the things he came to Africa was to find somebody he would like to help. And he told me that I was the one. That was after an operation, the day before he left to come back to the United States. And he told me that I was the one, and he would like me to come to get 6 months of training at the Mayo Clinic for knowing how to do craniotomy, how to treat hydrocephalus for this kid, how to treat some of those like laminectomy for myelomeningocele. But our program didn't accept me to come for 6 months because the principle is to train African surgeons in Africa to work in Africa. So it's not to come and train somebody here and send him to work in Africa. It's not going to work like that. And then they say, if I'm on vacation, I can come to observe 1 month, but not like a normal rotation. And that's why I came during my vacation. Actually, I'm on vacation during this month, but I've tried to share it and try to give it like a gift or my contribution for trying to work for the future of Tandala. So I will accept to be having one weekend to rest, but work throughout the week to find what we can do for the future of Tandala.
Mifila?
Yes.
Yeah, I would probably see now if there may be some questions.
Yeah, I think that's a good. Yeah.
Or unless you wanted to ask some specific things, Susan.
Are you the only physician at Tandala?
I'm not the only physician there. We have, for now, there are 4 physicians working there, general practitioner, most of them. And yeah.
What's the name of the doctor from the old clinic?
His name is Kendall Lee. Kendall Lee. He's the one who is working for treating Parkinson's disease with patients with tremor. He's putting what they do, DBS, is deep brain stimulation. They will open your brain. They will go with a small implant and place inside the area that is in trouble, that makes you to have your hand shaking, for patients with Parkinson's disease. And he is also the director of the Mayo Neural Engineering Lab in the Mayo Clinic. So he's he's from South Korea, I think, but he's American. His parent was in Korea. So, and he's, yeah.
How hard would it be to get something there like we have these flashlights that you can just shake because you don't have to charge batteries, you just shake them.
Oh, okay.
And then you have instant light.
Oh, yeah.
Or you can crank something that's bigger.
Okay.
And it just cranks the battery, and you don't have to replace a battery or charge a battery.
Yeah.
How hard would it be to get something like that to temporarily move?
I think that will be very, very helpful if we can get that. That can even go with somebody in maybe his luggage. Just put it there and then go with it. But here we have.
If a team is going over, for example, you could send it with a team. But I'm gonna say
About Facebook, maybe.
right. You can be looking for
sorry.
a Facebook group called Friends of Tandala, which is going to start looking at some of the things like that. Our church has a fairly good expertise on how to get things shipped door to door now. We understand the process finally because we send a lot of hand tools over there for the carpenters. So we know how to do it. So, but look at it for Facebook, or if you guys want to do a collection or anything, I can tell you how to get it there.
Okay.
Yes, sir. Oh. Well, you're the pastor. I'm the guest.
Okay.
Did you, when you're going to school there, do they speak in English? Is that how you know English?
In Cameroon.
In Cameroon, where I'm doing my training, is an American missionary program, so it's English. Because it's English.
We speak 6 languages. At least.
Thank you.
So,
Thank you.
We're going to give you an opportunity to ask him some more questions when we dismiss today. We have an opportunity to eat downstairs.
Okay.
And all join together. You're certainly welcome to ask him any questions you'd like while he is down here and around. He's going to be here for a little while today, I think.
Yeah, sure. Yeah.
1:45-ish.
By 1:45 have to go, but that'll give you some time to do that. But we're going to